the disorders that affect the male reproductive system. And of course, when you look at the reproductive system, we know mostly it involves, of course, more importantly, the testes. And we know at the testes is where the spermatogenesis takes place. And we know that it's produced in the testes, then matures in the epididymis, and then it's transported through the vas deferens or different duct all the way, and it connects to the seminal vesicle. You can see the seminal vesicle posterior to the bladder, and then connects to the prostate. And that is where in the prostate, that is where you get ejaculatory duct, where the secretion from the prostate, which constitute around 60% of the semen. Yeah, so 60% of the semen volume is produced in the seminal vesicle. That is why most of the time it's called semen. And the other 30% comes from the prostate. I think 30% is from the prostate, the secretion from the prostate, and another 10% usually is from the bulbourethral glands. There are some glands around the urethra, around the bulb region, bulbous urethra. There are some glands that secrete mucus. So those the contents of the semen, which I think we did in the first year, 30% will be from the prostate, or 60% is from the seminal vesicle. Alafu 10% basically is sperms. So in a semen, there is only about 10%. 10% only is the spermatozoa. And then, of course, they come together, and there is the ejaculatory duct in through the prostate, and then now it comes to the urethra. And you can see the urethra, there is the part that goes through the prostate, that is called prostatic urethra. And then we have membranous urethra just after at the tip of the prostate, we have membranous urethra, which is usually the most fixed and the shortest. So that is the part that is usually injured in injuries, pelvic injuries. And then we have the bulbous urethra, then we have the penile urethra. And we said in male, the urethra is around, I think, 20 to 25 centimeters. In the female urea, it's about 4 centimeters, much shorter. And then, of course, we look at the penis as part of the male reproductive system. And the penis is made of those erectile tissues, where we have the corpus cavernosum, which is one. So we usually have two, corpora cavernosa. And then we have one corpus spongiosum. And the corpus spongiosum is where the urethra passes through. And you see the glans penis, it's good to note that it is basically a distal expansion of the corpus spongiosum. Yeah, so basically that is that from that particular diagram there. You can see other relations like the rectum. You can see between the rectum and the bladder, we have rectovesical pouch. Yeah, so we move on. Again, you can see the prostate from posterior. The upper diagram is looking at it from the posterior, where again you can see the ureters, of course, as it joins the bladder. Ureter is that is conducting urine from that has been made in the kidneys to the bladder where they are stored. And then you can see the relations with the different ducts. Those are vas deferens that brings and join with the seminal vesicles to form the ejaculatory duct through the prostate gland, where now goes through the urethra. And you can see on that will be sagittal section that is cutting through that plane. You can see the bladder and the relations with the prostate gland. You can see the ejaculatory duct, you can see the seminal vesicles, and you can see the different ducts. So that is the vas deferens. That is where the semen is conducted through. Yes, there's another diagram of the prostate, looking at it from the front. This will be coronal. The upper diagram will be a coronal section of the part of the prostate and also the urinary bladder. So you can see the urinary bladder, you can see the mucous membrane, which is made mostly, as we had said, of transitional epithelium. Mostly that's epithelium, which is transitional epithelium. And you can see around it, there is the blood vessels. For example, the one that will surround and supply mostly these ones are made of veins, vesicle veins. Those are the veins that drain the prostate and even the bladder. And you can see at the prostate, we're calling it prostatic venous plexus. And then you can see, of course, the prostate. You can see there prostatic sinus. You can see the prostatic utricle. When you talk of utricle, it's almost talking about a small uterus. So it's a utricle. It's a very small uterus-like, but it's a very small outpouching from the prostate at that level. We call it utricle. And then we have urethral crust. And then you can see there urogenital diaphragm. That is where you will find the membranous urethra. That is the one that is the most fixed. And so in case of injuries, that is the part of the urethra that is mostly injured because it's the most fixed. And then you can see there, that is where also at the urogenital diaphragm, that is where we have the external sphincter. For the male, we have internal sphincter at the bladder region just before it enters the urethra, and then we have another sphincter at that urogenital diaphragm. So, of course, the external sphincter, which is at the urethral diaphragm, is the one that gives us conscious continence. That is the one you're able to control consciously because that diaphragm, there's a muscle, there's a skeletal muscle there. And then the internal sphincter mostly is made of smooth muscle. So this one, you don't have much control over it. And then you can see again the bladder there and the prostate, that is sagittal plane. You can see the same thing that we are looking at. You can see it as, sometimes divided into 5 lobes. That is the prostate. We have the anterior lobe, one anterior lobe, then we have a posterior lobe, then we have one median lobe, and then we have 2 lateral lobes that we are not, it's not shown on this part. The one that when you look at the diagram down there, you can see the lateral side. So that will be, of course, those are just divisions that are not, if you have to look at it, there are no very definite division, but for the purposes of learning, sometimes we divide them into 5 lobes. And you can see the relations there. You can see even the prostatic urethra, you can see the prostatic sinus that you could see in one of the diagrams, and you can see the glands of the prostate. You can see the way the glands of the prostate are usually connected to by small ducts into the prostatic urethra. And you can see the prostate as a capsule. Yeah, and you can see the prostatic venous plexus. So those are the veins that drain the prostate. So of course, during surgery, when you're removing the prostate, you need to be able to achieve hemostasis by making sure you tie those veins so that they don't bleed before you remove the prostate. Yeah, and then looking at the penis, you can see again the diagram. You can see the shaft of the penis. Then you can see the glans penis, which, as I said, is an extension or a continuation of corpus spongiosum, which the urethra traverses through the corpus spongiosum, as I've already said. And you can see the corpora cavernosa there too. Those cavernosa, so there are 3 erectile tissues, 2 corpora cavernosa and 1 corpus spongiosum. And then you can see the scrotum. As we have already noted before, that the scrotum, the location will be outside the body for the purposes of the temperature needs to be lower, usually around 3 degrees Celsius lower than the body temperature. And that is the temperature that is optimal for spermatogenesis. So it has to be lower than the body temperature. Of course, there is the scrotum that covers, that forms that bag, which is contained the testis. And we note, I think in anatomy 2, we did look at the walls of the scrotum. Usually the skin of the scrotum is hairy with corrugation, and usually doesn't have unlike the abdominal wall, which has the campus fascia, that is the fatty fascia. The testis, the skin of the scrotum does not have that fatty fascia or campus fascia, because if you were to put that, it will cause a lot of insulation and it's likely to increase the temperature to the testis, which we want it to be at a lower temperature than the body the rest of the body for the purposes of optimal spermatogenesis. And you can see, of course, the root of the penis that is made of corpus spongiosum and so on. And then you can see again the diagram there, that is sagittal cut, where you can see again the bladder. You can see the internal urethral sphincter, the one I'd say that is involuntary, just at the bladder wall. And then, of course, thereafter, we have the external sphincter at the pelvic diaphragm. That is now made of, the external urethral sphincter is made of voluntary muscle. So you are able to control the passage of urine using that external urethral sphincter. You can see the bulb of the penis. You can see again the corpus spongiosum through which the urethra passes, the male urethra passes. And then you can see the external urethral meatus, and then we have the prepuce, that is the foreskin. That is the one that usually during circumcision, that is what is removed, the prepuce in circumcision. You can see again the testis, and we've explained, you can see the dark difference. That is the vas difference. Generally, we know that the testis, the penis rather, will be made of 3 erectile tissues. And these erectile tissues are full of spaces. Yeah. So if you think about, even, for example, when you think about the lungs, I think we looked at the lungs last time. When you look at the lungs, it has a lot of spaces where it allows air to come in for respiration. Likewise, in the penis, we have these erectile tissues, 3 erectile tissues full of spaces, which are usually filled with blood during erection. And something to note is to know that the corpus spongiosum, compared to corpus cavernosa, usually the rigidity is less than that of corpora cavernosa. Of course, that helps because during, for example, ejaculation, the semen should be able to come out, because if the rigidity is hard, like for corpora cavernosa, then it's likely to completely close the urethra, and so the ejaculation may not take place. So usually in the most of the rigidity during erection will be brought about by the 2 corpora cavernosa. However, still, even the corpus spongiosum also contribute to rigidity, but it's not as much as the corpora cavernosa. And then you can see there those spaces which are usually filled with blood for erection to take place. So for erection to take place, usually blood flows in and rigidity occurs. And during detumescence, that is when the rigidity ends, the blood usually will reduce from these spaces, these vascular spaces, and the penis will become flaccid. And then, of course, we have there the route that would be taken by spermatozoa during ejaculation. And then you can see it starts, of course, with it is made in the testis. Yeah, those are the spermatozoa will be produced in the testis. And then it goes to the epididymis, where mostly in the epididymis, what occurs is mostly they are stored and they mature there. And noteworthy is the fact that the spermatozoa start developing motility once they leave the epididymis. So at the epididymis, the way the spermatozoa will move from the epididymis to the vas deferens or the deferent duct is through this epididymis has smooth muscle in its wall, so it contracts to push, to give a bit of support to push the spermatozoa to the epididymis. And once they come to the epididymis, to the vas deferens, they attain motility. Yeah, remember the sperm has a head, it has a body middle part that mainly is made of, which is made of basically mitochondria. And then we have the tail that now helps it move. So motility is attained once they reach the vas deferens or deferent duct. Yeah, so in the seminiferous, in the epididymis, which has a head, the body, and the tail, the spermatozoa are immotile. And then, of course, it goes there. And of course, during orgasm, there is contraction of smooth muscle within the vas deferens itself, and even in the seminal vesicle, so that it contracts to push in the fluid that is from the seminal vesicle that combines with the fluid and the sperm that is from the testis at the ejaculatory duct. And also at the prostate gland, prostate fluid also is released, because in the prostate also there are smooth muscles that contract to release the seminal or prostatic fluid into the urethra. And so all that comes out now through the penile urethra and finally comes out in the external urethral orifice during ejaculation. So that pressure, that force is what will bring them out. And it's good to remember that seminal fluid or semen is usually a bit alkaline. That is basic, because usually the vaginal environment is highly acidic, so it requires something that will neutralize the acidic environment within the vagina so that the sperms are not killed within that environment. So that environment needs to be neutralized with semen generally, because of the prostatic fluid, seminal fluid, and even the mucus from the bulb of urethral glands. They are acidic or they are alkaline. So reduce the acidity so that the spermatozoa that has been ejaculated are not destroyed. So that about, so you can see the pathway that it passes through. And then looking at the testis that has been cut, probably this is transverse or axial cut, the plane, and of course this is a diagram. And then you can see in that testis we have several cells. For example, we have the interstitial cells of Leydig. These interstitial cells of Leydig is the one that produce the hormone, the male hormone, testosterone. Yeah, so interstitial cells of Leydig produce testosterone. That is important in the formation of spermatogenesis. And then we have the Sertoli cells. Sertoli cells, basically, they are supportive. You can see they are within the seminiferous tubule. They are mainly supportive, and also they give nutrition to the developing spermatozoa. Yeah, so that is their work, Sertoli cells. So mainly support, protection, and nutrition of the developing spermatozoa. You can see the spermatogenic glands elements. Those are basically spermatogoniums that are developed to finally form spermatozoa. You can see as they develop inside the lumen of the seminiferous tubule, you can see the sperms start to accumulate there. And then from there, of course, it moves to the epididymis. Yeah, and then from the epididymis, they are stored and mature there. And finally, they are pushed out into the vas deferens, where they start developing the ability to the mobility that they require. And then, of course, looking again at the testis, when you look at that testis there, you realize you can see right from the testis, you can see the skin that we said it has many layers. Maybe you can go back and revise that. Among other things, you have cremasteric muscle, you have the skin, you have the dartos muscle, among others, all the way to the tunica vaginalis. You can see the tunica vaginalis, we said last time, is a potential space. And that is where fluid can accumulate and you end up with hydrocele. Yeah, so if excessive fluid accumulates within that cavity, tunica vaginalis, and you can see the tunica vaginalis, we have tunica parietal layer, and then we have visceral layer. Visceral layer is the tunica vaginalis that covers the testis, that is firmly adherent to the testis itself. And then tunica vaginalis, parietal tunica vaginalis is the one that covers the outer surface of the scrotum from the inside. And then you can see the seminiferous tubules, the lobules, that inside it has the seminiferous tubules is where the sperms are formed. And finally, they get through the efferent ductules into the epididymis. And you can see the epididymis is basically a highly coiled tube. So they say usually it's around 6 meters. So you can imagine how coiled. So it's markedly coiled into that small space behind the testis. So if you are to stretch the epididymis, it will get up to even 6 meters. But it is highly coiled, of course, small and highly coiled to just fit and form the epididymis, where we have the head, the body, and the tail of the epididymis. So in the epididymis, as I've said, that is where maturation takes place and storage of the sperms takes place. And finally, they are ejaculated, or they move to the vas deferens or deferent duct, where they moved up so that during ejaculation, they come out. But of course, if ejaculation doesn't happen, as maybe probably for many of our young men there, they are not married, so they have no reason why they should be ejaculating at all. So usually after some days, the spermatozoa dies and they are reabsorbed within the epididymis and even the ductus deferens or vas deferens, and they are reabsorbed back by the body. So usually it will not cause any harm. And you can see in the spermatic cord also we have, so in the some of the contents of the spermatic cord, which if you remember from anatomy 2, one of them is vas deferens or the deferent duct. Another one is the blood vessel. We have testicular artery, we have testicular veins, which sometimes we call them pampiniform plexus. And then, of course, we'll have lymphatic vessels there and other things. Of course, that is important, especially when you think about testicular torsion, because testicular torsion occurs at the spermatic cord, where the spermatic cord rotate around itself severally. And so the blood vessels will be obstructed, especially the veins. And so that may lead to gangrene or necrosis of the testis in testicular torsion. So it's important to know the contents of the spermatic cord. The most important would be the arteries and even the veins, because those are important in the scenario of torsion. When it rotates around itself, when it rotates around itself, you have the torsion. So looking at, again, just another developing, we are looking at the spermatogenesis, just to remind ourselves about what we did in anatomy 1. You can see there is the spermatogonium, which are basically the primordial germ cells. And finally, they develop into primary spermatocytes. And the primary spermatocyte finally develops and becomes the secondary spermatocyte. Usually, from primary spermatocyte to secondary spermatocyte, there is more of multiplication. So there is just multiplication of those cells, the primary spermatocyte to secondary spermatocytes. And from there, from secondary spermatocyte to spermatids, that is where now meiosis takes place. And remember, meiosis is reduction division. So that when you look at as in secondary spermatocytes, they are still diploid, that is 2N. They have the entire 46 chromosome. But by the time you come to the spermatids, you have haploid cells. So there are 2N. There are 23 pairs of chromosomes at that stage of spermatid. But it's good to realize spermatids, most of the time, unlike what they've drawn there, they're usually still just rounded cells with a nucleus and all. So it has not developed that morphology of a sperm, where it has a head, a body, and a tail. So usually from secondary spermatocytes to spermatids, we have what we call spermatocytogenesis, if you remember from anatomy 1 embryology. And then from spermatids to finally become spermatozoa, to develop that configuration of a sperm where it has a head, a body, and a tail, there's what we call spermiogenesis. So go back and revise again. That is what now causes it now from being a rounded cell to having a cell that has a head, a body, and a tail. So that is called spermiogenesis. So after that, you have mature spermatozoa. Spermatozoon, one will be spermatozoon, many will be spermatozoa. And remember, they are mature, but they usually are attached initially to Sertoli cells for the purposes of nutrition. And when they are released, they usually don't have motility, that is, they are not able to move. They are usually pushed from seminiferous tubules to the epididymis through just contraction with the smooth muscles within those ducts. And even within the epididymis, as I've said, there are smooth muscles that push it, because, as we said, spermatozoa attain that ability to move only once they come to the vas deferens.